Okay, hello, my name is Hidalgo. I am talking about necrotizing soft tissue infections. Okay, about the definition, necrotizing soft tissue infections tends to occur in immunocompromised patients with degenerative disease. However, this infection also occurs in people with no pathological history due to a set of aerobic and anaerobic microorganisms which enter to the body through a minor wound or scrape. The bacteria begin to multiply and release harmful substances like toxins that destroy tissues and affect blood flow in the area of location. This infection in turn spread rapidly affecting the subcutaneous tissues in addition and spread into the tissues deeper.
And systemic signs of toxicity. NSTIs can include involvement of the epidermis, dermis, subcutaneous tissue, fascia, and muscle. The pathophysiology of these infections is the same and is the result of either bacterial penetration of skin and mucosal defenses after tissue injury or with origination in the deep tissues without a clear portal or source. Bacteria gain entry into areas of relatively poor blood flow and hypoxia, which is followed by bacterial overgrowth, release of exotoxins causing local tissue damage, and widespread necrosis. Type 1 NSTIs or polymicrobial infections are most common and typically seen in patients with comorbid conditions. Gram-negative enteric bacteria are seen in combination with gram-positive organisms and anaerobes. Type 2 is monomicrobial, usually due to group A strep, has a more virulent course, and occurs in younger, healthier patients. Certain comorbidities and risk factors may predispose patients to this disease, including advanced age, obesity, diabetes, alcoholism, vasculopathy, IV drug use, immunosuppression, end-stage renal disease, perirectal abscess, perforated viscus, and recent surgery. Exam findings can include erythema, swelling, induration, and early tenderness. Late findings can include skin discoloration and a violaceous erythema, bulla and crepitus, pain out of proportion to examination, or anesthesia of the affected area. Most patients quickly develop signs of systemic toxicity, including high fever, nausea, vomiting, malaise, altered mental status, tachycardia with associated hypotension, and oliguric renal failure. Lab findings may include a leukocytosis with left shift, acidosis, hyponatremia, elevated lactate, and elevated inflammatory markers. Imaging is not necessary when there is a high level of suspicion and may delay early treatment. When the diagnosis is unclear in a stable patient, CT findings consistent with NSTI can include gas across tissue planes, fluid collections, asymmetric fascial or muscle thickening, and diffuse areas of soft tissue inflammation. The mainstay of treatment is aggressive early surgical debridement. Debridement should extend back to viable soft tissue and muscle that exhibits brisk bleeding. Return to the operating room within 24 hours or earlier for a second look should be strongly considered.
Okay, about the applications in medicine, depending on the etiological agent, two diagnostic entities could be defined. If in type 1 polymicrobial, this is usually a polymicrobial infection causing 2 out of 3 cases, but at least one anaerobic germ and one or more faculty anaerobes and enterobacteria, whose synergistic action cause infection almost all in the patients of extreme age with chronic disease. Vibrios and Aeromonas are occasional cause of IFM. IFM type 2 streptococcal, this is usually a monomicrobial infection mainly caused by a group of beta-hemolytic streptococcus and less frequently by other species such as Staphylococcus aureus.
Okay, so prior to me coming to Mayo, I was a general surgeon, trauma surgeon, and burn surgeon at Upstate Medical Center in Syracuse, New York. And there I got an interest. Well, I was the burn surgeon. We handled a lot of the necrotizing soft tissue infections, and that remains an interest to this day. And for southeastern Minnesota, we do get the majority of the necrotizing soft tissue infections. So hopefully this is a review. There are a few things that I'll point out that are newer. Okay, so these are the demographics. And basically what this means is for most surgeons in the United States, you're going to see one of these cases every couple of years, so you'll be affected by it. You know, the flesh-eating bacteria, the group A strep, the clostridial those are not as common as the synergistic bacterial gangrene or the polymicrobial, which tends to have a more indolent course. And we're certainly seeing that in our patient population as they age, as they gain weight, and increasing diabetes. Mortality, depending on location and ability to control it, and etiology is between 16 and 34%. Okay, I like this picture because, you know, the term we use, necrotizing fasciitis, is actually wrong. That if you look at the majority of soft tissue necrotizing infections, they occur somewhere between the superficial and the true deep or muscular investing fascia. And that's why the term necrotizing soft tissue infection is preferred over necrotizing fasciitis. And I'll just point out in this picture, these are the perforating vessels that come from muscle and supply skin. Remember, skin has a longitudinal blood supply, which is can keep skin alive for several centimeters, but the perforators are the more robust blood flow. And so a lot of the signs that you'll see externally of a necrotizing soft tissue infection are actually due to ischemic changes, due to loss of perforators. Okay, the microbiology, basically anything has been implicated in necrotizing fasciitis. I'll point your attention to the marine Vibrio species. We have a lot of fishermen along the Mississippi, and we occasionally see some Vibrio from waterborne wounds, fishing accidents, outboard motor accidents. So particularly if you're in any of the coastal waters or any warm water, if you have a wound associated with water, think Vibrio. Okay, the microbiology has been divided into the type 1 cases, which
Okay, about the pros and cons. In pros, we have uncommon infection, and cons, we have high rate morbidity and mortality, intense pains, affected tissues, red hot and rapid pulse. Patients appear seriously ill with high fever, tachycardia, altered mental status, and imputation. Emergency surgical management, which consists of a wide and complete resection of the debridement of all affected tissue.
Today we'll be reviewing landmark papers in necrotizing soft tissue infection from the East Landmark Papers in Trauma and Acute Care Surgery online resource. We identified several papers pertaining to the diagnosis of necrotizing soft tissue infection. This well-cited study discusses one of the most widely used scoring systems to assist with early diagnosis of an STI. This validated scoring system, the Lorenic score, is based on laboratory values found to be independent predictors of disease and can be used to guide management. This was a smaller retrospective review by Wall and colleagues to help distinguish between necrotizing and non-necrotizing infection. They found a model that was simple, highly sensitive, with a negative predictive value of 99% for diagnosing necrotizing infection. This tool may be useful when other laboratory parameters, such as those required for the Lorenic score, are not available. In terms of the role of CT scan, while CT scan should not delay operative intervention for an STI, this study finds that it may be a useful adjunct for ruling out the diagnosis of a necrotizing infection. In terms of the management of an STI, this well-cited study by Leslie Kobayashi and colleagues found that a delay in surgical intervention for more than 12 hours contributes to higher mortality, septic shock, and renal failure, and is associated with an increased number of debridements than patients whose initial debridement is less than 12 hours after admission. Similarly, this study, which was a smaller retrospective review, found that early surgical debridement leads to a significant reduction in mortality, highlighting the importance of early recognition and expeditious initial debridement in the management of NSTI. And finally, for the role of hyperbaric oxygen as adjuvant therapy in the management of necrotizing soft tissue infection, there is no consistent evidence to support the routine use of hyperbaric oxygen as an adjunctive therapy in the management of NSTI, and these findings were actually corroborated in a recent Cochrane review that failed to locate relevant clinical evidence to support or refute the effectiveness of hyperbaric oxygen in the management of NSTI.
About the issue applied in Ecuador, necrotizing soft tissue infection is commonly diagnosed in Ecuador. Most patients with soft tissue infections are referred from another health center at the primary level, which require early surgical intervention and antibiotic therapy for appropriate management. In the treatment of necrotizing soft tissue infection, in addition to requiring extensive and aggressive surgical debridement to limit its progression, it requires mandatory re-explorations and subsequent debridements which may be necessary every 24 hours until all necrotic tissue is eradicated. Okay, about the conclusion, the early diagnosis of necrotic of tissue infection is often difficult and of great importance for the prognosis. Many times it's confused with a mild infection such as cellulitis and will depend on the severity of the infection, the virulence of the germ, and the host resistance capacity. For this reason, it's one of the most important and most frequent causes in patients hospitalized in the internal medicine service. Taking into account in addition that if we can carry out adequate and timely management, make complications such as sepsis, tissue necrosis, amputations, and the need for graft placement, and even death can be prevented. Thank you.